So we've got our trachea that is going to split into right and left primary bronchi. Bronchi is plural. And then now we're going from the primary bronchi, we're going to split again, and these are going to be secondary bronchi. And we're just labeling these generations of branches G2. We're not going to go through all 23 individually, but just some of these first ones are important to look at the hierarchy. And so as we look at the split, this is going to be one that's unequal. Because our secondary bronchi, on the left side, we're going to have that one split into two, right? The bifurcation. But on the right side, we're going to have our right secondary bronchi split into, primary bronchi split into three secondary bronchi. Because a secondary bronchi is going to go to each one of our lobes of the lung. Now, why do we have three lobes on the right and two lobes on the left? The heart gets in the way, so there's not as much actual lung tissue on the left as there is on the right. So we go from our secondary bronchi. Now we're getting into tertiary, or the G3s. And with our G3, each one of these tertiary branches is going to go to a compartment within the lobes of the lungs. And these compartments are called bronchopulmonary segments. So these segmental bronchi, tertiary bronchi, that's just two names for the same thing. They are going to go to these completely isolated compartments. Now, these show 10 on each side. You might read somewhere in textbooks and other materials there may be 9, 8, 9. The number varies. Doesn't matter to me how many there are. It does matter to me that you understand that the segmental bronchi go to the bronchopulmonary segments. Because as I mentioned, these segments are isolated one from another. So if you damage one, you don't necessarily damage the entire functionality of the whole lung. Does that make sense? That's why they're sort of segmented off. Now again, as we go from our tertiary bronchi and we continue to branch, and we continue to branch and continue to branch more and more and more, we eventually get down to the 23rd generation of branches. And these we call terminal bronchioles. Now, what did we call the small arterial vessels right before we got to the capillaries? Arterioles. They were small arterial vessels. These are smaller diametered airways compared to a bronchus. That's why we call it IOLES, oles. And the reason that we have terminal here, highlight this, underline this in your notes. Typically, when you hear terminal, what do you think of? That's it, dead end, right? These terminal bronchioles are not dead ends. Did you get that? They're not. Terminal bronchioles are not dead ends from an airway standpoint. A terminal bronchiole, from a functional definition, is the last portion of the conducting pathway for air. You remember how we had the conducting pathway? And then after the conducting pathway, now we get to the respiratory pathway. So terminal in this case is simply the last portion of the airway in which no exchange of gases with the blood happens. So terminal bronchiole is the last final portion of the conducting pathway before the air is going to move into the beginning of the respiratory zone or the respiratory pathway. Did that answer your question? Okay. So terminal bronchioles, generation 23, the last part of the conducting zone. The next branch from terminal bronchiole is a respiratory bronchiole. You see how the name now reflects its function. and that's the beginning of the respiratory zone. And it's in these small bronchioles that you will begin to see random and fairly infrequent little bubbles that we call alveoli. Those are where gas exchange is going to occur. And since you begin to see them on this bronchiole, that's why we say that's the very beginning. Not a lot's going to happen there, but since some does, that's the beginning of the respiratory zone. Now, we've not gotten to the end yet. We're still coming down, and here you can see our bronchiole, terminal bronchiole, and there's our first respiratory bronchiole. And these little balls that you see here, okay, those are illustrations of alveoli, and there's one right there on the backside of this respiratory bronchiole. And so the respiratory bronchiole gives rise then to alveolar ducts. Now, an alveolar duct sounds like a thing, but an alveolar duct really is nothing. Because all an alveolar duct consists of are alveoli that are arranged in a tube. So the alveolar duct is actually the empty space inside of this alveolar tube. Everybody understanding what I'm saying there? If you take the alveoli away, there's nothing left. It's basically this collection of alveoli arranged in a tube fashion. And the passageway is just the hallway inside those alveoli that are arranged as such. So you go from a respiratory bronchiole to an alveolar duct, and you can kind of see they've removed the alveoli, so you can just see that hallway. And that alveolar duct then goes to alveolar sacs. Alveolar duct is a tube of alveoli. Guess what an alveoli sac is? Just a sac, a rounded berry made up of alveoli. And that's what they're seeing down here. To me, an alveolar sac looks like a cluster of grapes. And again, you've got these air spaces on the inside in which air can flow into each one of these alveoli. And in fact, there are little holes between each one of these alveoli that are neighbors that the air can equalize between individual alveoli. Now, where gas exchange occurs, and I've already said it a couple of times, but I want to make sure we understand it. Gas exchange occurs at the membrane within each alveoli. And alveolus is singular, alveoli is plural. And this alveoli basically is a bubble of simple squamous epithelium. What is simple squamous? What does a simple squamous cell look like? It's a fried egg. That is a simple squamous epithelium. Where the yolk is, that's the nucleus. The flat white, that's the membrane of the cell. And what we're going to have is we're going to have these alveoli that have the simple squamous epithelium. They're going to be pushed up against the simple squamous epithelium of a capillary that we call endothelium, and that's going to be the respiratory membrane. Those two membranes of the alveolar cell and the endothelial cell, that's your respiratory membrane that the gases can diffuse across fairly easily because they're so thin. That's why it has to be simple squamous. You can't have a columnar cell, you can't have a cuboidal cell. That's too far for the gases to diffuse rapidly. And we'll get into more of our respiratory membrane as we talk about gas exchange in a little bit. So, how do these little bubbles provide you with enough oxygen and removal of carbon dioxide so you can function even under extremely strenuous conditions? Well, each lung has a bunch, up to 400 million with an M alveoli. And if you look at all of the surface area of all those alveoli between both of your lungs, the surface area you have to exchange gases is 70 square meters, which I think is around the size of a half of a tennis court. So if you think of gases moving across your gas filter, it's the size of half of a tennis court. That's how it can supply you with enough oxygen into your bloodstream and getting rid of carbon dioxide so you can function. And to me, that's pretty incredible. All those little bitty teeny microscopic bubbles can add up, and that's why you have so many of them. Now, we've already talked about the simple squamous epithelium of alveoli. Those are called alveolar type 1 cells. Alveolar type 1 cell. I bet you already know there's going to be a type 2, right? Yeah. So alveolar type 1, that's a simple squamous epithelium that is the respiratory barrier on the lung side. The endothelium of the capillary is the respiratory barrier on the other side. And alveolar type 2 cells, these are also called sometimes giant alveolar cells. I don't think they have the commercial anymore for the bathroom cleaner that had the scrubbing bubbles. Do you remember that commercial? They still have the scrubbing bubbles on the can. I'm talking to the guys like they clean anything ever, so I'm sure they don't understand it. Ladies, y'all have to explain it to them. But these giant alveolar cells, the alveolar type 2 cells, they always remind me of the scrubbing bubbles, because when you look at the thin epithelium of an alveolus, all of a sudden you'll see this big round dome-shaped cell sitting in there with them. These are the alveolar type 2 cells, and their function is to produce surfactant. Surfactant is very similar to detergent. Now, the other cleaning thing that I usually use as an example, are we familiar with the surface tension of water? Kind of know a little bit about the surface tension of water. Have you ever seen the insects, the water striders, that can walk on the water? And you'll see their little hairy feet as they're kind of pushing down into the water, but they don't submerge. That's the surface tension of water. You remember in AMP1 we talked about the hydrogen bonds of water that are holding the water molecules together? And I showed you a picture of the astronauts on the space station that were playing with the water droplet. What shape did the water droplet in the space station have? Completely round, because all those forces are trying to compact it down as much as possible. Inside each of your alveoli, because they're microscopic, it's very wet in those alveoli. So without this surfactant, the surface tension of water and those attractive forces that are lining the alveoli would pull them closed. And so with this detergent, it interrupts, because these molecules are amphipathic, meaning you've got a charge and a polar and a hydrophobic side. They break up the surface tension of water so that basically the air pressure you need to keep those alveoli open is zero. If you didn't have surfactant, they wouldn't open. And that's why preemie babies are really under respiratory distress often, because they don't have these cells to make a substantial amount of surfactant until probably at least 30 to 32 weeks of gestation. So if you have a preemie born in the 20 weeks, they may have to get exogenous surfactant, which is just basically a respiratory therapist shoots it down their lungs. Okay? They don't need it before then, right? Because what are they breathing? Amniotic fluid. I mean, it's all water anyway. But after that point, you're going to be giving the baby steroids and whatever you can to increase the speed with which you're producing the surfactant. Otherwise, you can never breathe deep enough and have enough pressure to open the alveoli. So these aren't just some trivial thing in there. This is what really keeps your respiratory system working.
Are type 1 cells the only simple squamous cells, or do type 2 cells, are they also considered simple squamous?
So it's hard to put a shape with these type 2s. They're not squamous because they're big dome-shaped cells. All the years I've taught histology, nobody's ever asked me that, because we do have some really dome-shaped cells in your body. Y'all haven't got to urinary yet in the lab, have you? When you get to the urinary system, you're going to see in the renal pelvises and in the bladder, you have these dome-shaped cells that are called transitional epithelium. Did y'all get that already in AMP1, the transitional? When they're stretched out, they look kind of flat, but when they're not, they're rounded. But these are not transitional, so they're just kind of special. Yeah. Yeah, I don't know what you'd call them. It's in the miscellaneous category. The other cells you're going to find that are pretty big are alveolar macrophages. And what name did we give alveolar macrophages in the lungs?
Dust cells.
Dust cells. So these are the dust cells that we were talking about as we were looking at that monocyte lineage and all the different names, the dendritic cells, the dust cells, the Kupffer cells. Well, that's what those monocytes are going to become here in the lungs, and they're going to help keep all the crap that you breathe in out of the system and help to eliminate it. And certainly any pathogens that might get in there as well. We've already mentioned gas is going to go across the respiratory membrane that's comprised of two flat squamous membranes, alveolar type 1s and the capillary endothelial cells. Now these capillaries are going to be the continuous type. I believe that's a type 1 endothelium. And there's really very little in the way of basement membrane between, because you want that as thin as is possible. You can't simply have the blood and the air in the lungs mixed together, so that's why it has to be separated, but by a very, very thin respiratory membrane. So here we're looking at the lungs and we're looking at the bloodstream. I'm going to go ahead and introduce this. We're going to exchange gases. Do you remember what kind of respiration we said this is? That's more cellular respiration. We'll get to that.
Was it active?
Now that's around ventilation. We're going to talk about active and passive ventilation. Haven't got to that yet. Say it again. External respiration. I believe I mentioned that because when you think external, you're not thinking inside the lungs. But when gases are exchanged between the blood and the air in the lungs is the same as the external air. You've simply moved that external air into the lungs. That's referred to as external respiration. We're going to cover that more in just a second. But since we're here, I just wanted to point it out. We have our blood, we have our alveolar space. So for external respiration, oxygen is going to diffuse into the capillaries from the alveolar space, and carbon dioxide diffuses into the alveoli from the blood. See, here you have the red oxygen moving in, you got the blue CO2 moving out of the blood. Diffusion, how much energy are we using? It's passive. There's no energy expenditure. How are we not using energy and these gases are moving in completely opposite directions?
Concentration gradients.
It's a concentration gradient. And with gases, it's going to be a pressure gradient. But it's exactly like looking at water moving with solutes, high to low, and osmosis. It's going to be the same, except with concentration gradients. Now it's going to be a pressure gradient. So y'all should be fairly comfortable with those gradients, and we're going to be playing with these gases that way.
So it's both, it's pressure and concentration gradients causing
I want to do with pressure. Okay. Certainly increased pressure could mean you have more of the gas there. However, a greater pressure could mean you don't have more gas, but you have restricted the volume of that gas. You put pressure on it by decreasing the space, which increases the pressure. Because we're going to play with gases that way too. As we look at where the lungs sit inside our thoracic cavity, you understand that in here it's going to be surrounded by our rib cage. And you've got the curved portions of the lungs on the outside, or the lateral portion. And on the inside portion, there's sort of an indented, I wouldn't say it's necessarily concave, but you're going to have an indention on the inside, which is our hilum. We've already seen the hilum in a number of organs, the spleen, we've got the hilum in the lymph node. And so that hilum is going to be pointing more medially, and it's going to be on the inside of the hilum where we see the blood vessels and nerves and lymph vessels and the bronchi. All that's going to be entering and leaving the lungs on that indented hilum side and not on the curved exterior side of the lung.
Is the hilum specifically on the left side, or is it both?
It's both. I mean, you can kind of see under here a little bit, but since we're facing this one head on, you can't see. But they both have the hilum, the right and the left lung. All right, we're just about to the point that we can start playing with gases. And typically when we think a lot of these membranes that line our body cavity and cover our organs, we don't think about them a lot. We don't think that they're doing a huge, tremendous deal. But here with the respiratory system in the lungs, they're quite important. And we have two of these membranes that we call the pleura. And understand these are simple squamous epithelial membranes. In a generic sense, we refer to them as mesenteries and mesothelium, like endothelium inside the blood vessels. Mesothelium is like the mesentery of your body cavities. And these membranes can either be attached to the body wall musculature, and in that case, we refer to them as parietal. And if these membranes are adhered to our organs, or what is a generic word for organs? The viscera. So that is why we call this the visceral portion. Now, pleura simply means these membranes are in the thoracic cavity associated with the lungs, or the pleural cavity. Pleura refers to lungs and respiration. So we have one that's going to be on the surface of the musculature, lining the thoracic cavity, and the visceral pleura is going to be on the outside, adhering to the surface of the lungs. Okay?
This is known as the serous membrane.
It can be a serous membrane. I mean, serous often refers to excretory or wet. And so these things, again, being a mesentery, and in this case we rename them the pleural membranes, either on the organ, the lungs, or on the body cavity.
Okay.
Now, the one thing in particular that makes this important is because the lungs are going to be pushed right up against the thoracic body wall. And you don't want the lung tissue adhering to the body wall tissue. You want it to be frictionless. So by having these membranes against each other, that helps prevent adhesions, and it sort of lubricates, if you will, the movement that may happen between the surface of the lungs and the body wall. That's going to create a potential space. Do you understand in anatomy what a potential space is?
Yes, sir.
You don't have a space under normal circumstances, but you could. And so in this case, when we look at our, let me get oriented here, our visceral pleura, this is our lung tissue, and this light pink band, that is going to be the covering on the lungs, the visceral membrane. And then we also have the parietal, so here's our muscle wall, there's going to be one of our ribs, and this light pink there, that is our parietal pleura, or parietal membrane. But notice this says pleural cavity. That cavity, which is going to be our intrapleural space, we're going to get to that in a bit. I'm just going to go ahead and introduce it to you. Intrapleural, pleural means what? Pleural, we're talking about the pleural cavity. So intrapleural space is going to be this space between our pleura. We're also going to hear about intrapulmonary space or pressure. Where is intrapulmonary? Inside the lungs. So keep pulmonary inside the lungs separate from pleural, which is the space between the membranes. Okay? So I'm going to go ahead and introduce this concept, which is critical in understanding how respiration works and ventilation. and we'll talk about it more as well. When we look at our visceral pleural lining the lungs, okay, and we've got this other membrane outside sealing that off, there's that space between, potential space. The pressure inside your lungs, your intrapulmonary pressure, is always going to be about 4 or 5 millimeters of mercury higher than the pressure inside the pleural space. I'll say that again. The pressure inside your lungs is always going to be about 4 or 5 millimeters of mercury, that's the pressure reading we're going to be playing with, higher than the space outside the lungs between our pleura. Now, we've already talked about the gradient and how air is going to move from high pressure to low pressure. So with the higher pressure inside the lungs than outside the lungs, that's going to push the outside lung, that visceral pleura, it's going to push it up against the parietal pleura, and they're never going to move away from each other. When you inhale, as your rib cage expands, that's going to pull the lungs out. Have you ever seen one of those baffles that blacksmiths have to stoke the fire? So when we inhale, it's like opening it up as our rib cage expands and it pulls outward the parietal pleura. Because of that lower pressure, it's going to pull the lungs outward and help to inflate the lungs. As then we exhale and the rib cage makes a smaller space, we're putting pressure inside the air in the lungs to force it out, but yet the pressure is still going to be a little higher in the lungs than outside. So it's just, they're going to move like this. Your visceral and parietal pleura, they're never going to be moved apart from each other. There's one time where you can separate the two. And it's called a pneumothorax, or a collapsed lung. If you get a shank or a knife stabbing you, now that intrapleural space is going to equalize with your air out here, and then the lungs, because they're not going to be pushed against the side of the body, they're going to what? Collapse. And that's why they collapse. And that's why they don't until you have an injury. Respiration. This is what we kind of introduced with external respiration when we talked about it. So one thing when you say respiration, some are going to say, oh, that's breathing. Respiration is breathing. So you can apply that term to it, but really ventilation is more what we talk about with breathing. Then once we move the air into our alveoli and exchange gases, that is our external respiration. Then we're going to move that gas around in the blood until we exchange the gases with our tissues of the body. That then is going to be internal respiration. So the two big ones we're really going to talk about a lot are external, that happens in the lungs. I know that sounds like an oxymoron, external in the lungs. And then internal down at the level of our capillaries and our tissues. Now, the last respiration is cellular respiration. That's what happens in the mitochondria. Well, cytoplasm mitochondria, but we did that in AMP1 and we're not going to go back. Aren't you glad? We could if you wanted to, but... okay, I think you asked about the other gases, right? So here we're getting into some of the properties of gases that are important to understand so we can see how these gases are going to move. And one of the physical laws that deal with gases is called Boyle's gas law. So Boyle's law basically says as a pressure of a gas decreases, so as you put less pressure on a volume of gas, so the pressure of the gas decreases if the volume that contains the gas increases. So the pressure of a gas is going to go down as the volume that contains the gas gets bigger. And so in this case, you've got a certain volume, and we've got a little piston here to kind of illustrate. So you've got a gas in here that's got a certain amount of pressure on it. If you push that piston down and you have the same amount of gas inside, but now that gas is compressed to a smaller volume, now that pressure is going to go up. So this is an inverse relationship between a pressure of a gas and the volume of a gas. And kind of like we talked about already with osmosis and having two areas and which way does water move, downhill, that sort of thing. Well, with our pressure of our gases, it's going to be from high to low pressure, just like we talked about, which is good because we need that to happen in our lungs and in our capillaries with our tissues. So when we talk about pressures, some of these you probably already know. Atmospheric, the barometric pressure. So we know when a high pressure center is coming in or a low pressure system is coming in. When you get older, your knees are going to be able to tell you without looking at the weather. And I have always heard that my entire life.
And now you understand it.
But I understood it as soon as I recovered from my ACL knee surgery. Because as soon as that happened, I could tell you when it was going to rain. Anybody else? Anybody else get, yeah. You just, with your joints, and especially when you get older, that air pressure, do what?
Is it going to rain tomorrow?
Is it going to, no.
It's going to rain on Thursday.
Although my legs ache all the time, so it's harder to tell now. Yeah, oh wait, the left one says, yeah, rain Thursday. No, I'm kidding. Barometric pressure, if you've ever gone into the mountains, have you noticed it's harder to breathe? Because the pressure at altitude is lower, and that pressure difference is going to affect the ability of oxygen to move into your blood. So that again is an example of what we're going to be dealing here with pressures. Alveolar volume, this is simply if you add up all that area, you know, we said we had that 70 meter squared surface area of the alveoli. We've got a certain volume, and that's going to be the space which you add up with all the alveoli that they can hold this air. Now, also understand this. When you ventilate, you are not completely exhausting all the used air and bringing in completely fresh air. It's going to be a mixture of that. If you completely exhausted all the air from the alveoli and your airway, everything would collapse. So you're bringing in fresh, but it's still going to mix. There's a dead volume of air that's left over after you completely, as much as you can, exhale. There's still a volume of dead space that's in there. Okay. So let's start with ventilation. So we're going to have inhalation and exhalation. Again, I like those terms because expiration means you're dead. So I kind of avoid that, even though the book uses that quite a bit. But we're also going to talk about different types of breathing. Right now, most of y'all are doing quiet ventilation. Now, some of you are a little louder when you're sleeping, so anyway, we won't go there. But you're also going to have, and quiet could be passive. Okay, you're at rest and you're not utilizing the full scope of your respiratory system. However, if any of your athletes or do strenuous activities, you're going to know when you work out, when you exercise, when you run, play football, do cheer, all that kind of stuff, you're going to breathe heavier because your body is demanding more oxygen. So right now, you're only using a fraction of the system. When you need more, your body can provide more up to a certain level, and that's going to be active breathing, active inhalation and active exhalation. All right? And we'll get to the mechanics and the specifics of those as we move forward. So let's start. Quiet breathing. One of the muscles that's going to be active with quiet inhalation is going to be the diaphragm. Now, at rest, and it's never going to be at rest very long, or at least you hope not, your diaphragm is going to be dome-shaped. Your diaphragm is going to attach on lateral surfaces here. I believe these are called the costodiaphragmatic recesses down in here, these little ears down here. They attach down low, And you can see the diaphragm curves up. So when that muscle contracts, it's going to flatten. You see, this is when it contracts. It's flattening and moving downward. So the diaphragm is the floor of the thoracic cavity, right? So when the diaphragm flattens during contraction, what's going to happen to the volume of the thoracic space?
Increases, of the which space?
The thoracic space, all the space in here. You drop the floor, the volume increases. When the volume of that space increases, what's happening to the pressure of the air inside the thoracic cavity? It decreases. Remember, volume increases, that Boyle's law. It's the inverse for pressure. So as you increase the volume, you're decreasing the pressure. Now, we've inhaled, we've dropped the floor, we've got some other things that we're going to do too. But when we need to exhale and we relax, the diaphragm is going to spring back up. Exhalation is a passive process. The muscles you contracted to inhale, you just simply relax them and it goes back. And the diaphragm's one of those. When you relax, the diaphragm springs back up. What's happening to the volume now when we exhale? The volume decreases, and what's going to happen to the pressure? Increases. Remember, it's inverse. So as we breathe in a whole bunch of air and fill that space, because remember we lowered the pressure, pressure is going to be higher outside the body, so that's a vacuum, the air is going to rush in, it's going to be sucked in. Now when we exhale, we're going to create a higher pressure because we've got a lot of air in there and we decrease the space. Now that high pressure is going to be pushed out because that pressure is higher than atmospheric pressure. So do you see how we're literally going?
So when you exhale, the diaphragm goes up.
When you exhale, the diaphragm relaxes and goes up and it forces that higher pressure air out. Now we're going to play with the rib cage and some of our intercostals, but well, we're going to do it right here. So looking down at what's happening with our rib cage. So when your external intercostals, do we understand what intercostals are? You remember this from AMP1? Where are the intercostals? In between the ribs. In between the ribs. Where are the external intercostals? They're on the outside. Get it? External? Where are the internal intercostals? They're on the inside. Oh, isn't that so easy? We're going to be playing with both of those. But for quiet breathing, we're just using your external intercostals. And when you contract your external intercostals, they're going to elevate the ribs. And as your intercostals pull on each one of these ribs, the entire rib cage is going to be elevated. And because of the attachment of the sternum, your ribs are going to move up and the rib cage is going to expand outward. What are you going to do to the volume when you contract the external intercostals? The volume of the space does what? Increases. This is with inhalation. And what's going to happen to the pressure? Decreases. Just like that. So the diaphragm drops. That increases the volume. Your rib cage is going to move up and out. That's going to increase the volume again. Both of those are going to contribute to the lower pressure for inhalation to suck the gas in. Now, when you relax the external intercostals that raise the ribs, when you relax them, what's going to happen? Does the rib cage stay there? What happens to the rib cage? Relaxes. The rib cage relaxes? We relax the muscles. Well, what's going to happen to the rib cage?
Well, it stays the same shape roughly, right?
Does it just stay the same shape as it did? No. It's going to return to the original position. How does it return to the original position?
The muscles just relax.
The muscles just relax, so they're not pulling them down.
The pressure.
Huh? No, the diaphragm is kind of pushing up. Gravity. Gravity pulls the ribs down. I mean, we got gravity, might as well use it, right? It's free. Yeah, and that's why I always wondered, man, on the space station, they have trouble with respiratory stuff because they don't have gravity pulling. Have you ever tried to breathe upside down? Have you ever been on the inversion boots just for kicks, or one of those, what are they called, the teeters? Yeah. You know, that old people kind of have. If you're upside down, it's hard to breathe because now gravity is not going to be pulling your ribs back to your normal position. So I wonder if astronauts have that issue. I don't know.
During exhalation, since there's an increase in pressure, is there proportionally more diffusion occurring since there's an increase in pressure?
So is there proportionally? I think potentially yes. Now, again, remember, we're talking about inside the lungs, and I don't know how long that pressure would be high enough to make a difference. But in that case, then you're also going to offset that with lower pressure during inhalation. So it's going to be kind of an average. Yeah.
Diffusion's always happening.
Oh, yeah, it's always happening to a certain degree or another. All right. So we kind of understand what our muscles are doing to increase the volume to inhale, decrease the volume to exhale in quiet exhalation. Now we're going to put a few numbers together here. So we're still in quiet breathing. Now we're specifically talking about our inhalation step. And we're going to start off with 760 millimeters of mercury. Now this is kind of that standard, 98.6 or 120/80 number. But this is what we're going to use as 1 atmosphere of pressure. So at sea level, atmospheric pressure is 760 millimeters of mercury. So to start with, we're going to say our intrapulmonary pressure. Where's that? Intrapulmonary, inside the lungs. So to begin with here, we're going to have the same pressure inside the lungs as atmospheric pressure. That's where we're starting. So we got 760 inside, 760 outside. Which direction is air moving? This is a trick question. This is a trick question. Where is the air moving? It's moving both. Remember, things are always moving, but what's the net movement? The net movement's zero. Because you got some moving in, some moving out. It's ISO, so I got you, Hugh. Now, remember, intrapleural, the space, it's going to be a little bit lower, so the visceral and the palatal pleura are still slammed up against each other. There's no actual space. All right, now let's move it. Now, the diaphragm is going to contract. And where does the diaphragm go when it contracts? Down. Again, this kind of isn't intuitive. That's why I keep repeating this part. The diaphragm is going to move down. The external intercostals are going to contract and cause your rib cage to do what? Expand. I like that, expand, which is up and out, but you can say expand. So we've increased the space inside our lung, our intrapulmonary space. Now that was 760, right? If we increase that space, that pressure is going to go up or down? It's going to go down. And you can see in our illustration, they're showing that it went down to 759. It's probably going to drop even more than that. But even 1 millimeter of mercury is enough difference between our 760 to cause air to move in. So the air's going to move in until you equalize the pressure between atmospheric and in your lungs, or until you do something else with your muscles. And what this is going to be, Hugh, was it you that talked about tidal volume? I wasn't. Okay. Tidal volume is basically the volume of air that moves in and out of your lungs, kind of like the tide on the beach. Got high tide and low tide. So that's what they're talking about. And invariably, that's going to be half a liter. That's just moving in and out. Certainly, you've got a lot more volume inside your lungs than 500 mils. Now, again, we've already touched on this. You've inhaled, you've contracted your diaphragm, you've contracted your external intercostals. Now it's time to exhale. What muscles do you contract for quiet exhalation? What muscles do you contract for quiet exhalation?
Just your diaphragm and intercostals.
Which muscles do you contract for quiet exhalation? It's a trick question. It's a trick question. None. You relax those two. Yeah, you don't contract any muscles. You simply relax the diaphragm. Whoops. You relax the diaphragm and the external intercostals. When you relax the diaphragm, where does it go? The diaphragm moves up, and when you relax the external intercostals, what happens to the rib cage? It moves down, and it sort of, it doesn't expand. What do we say? Collapses? I don't like collapse. What's the opposite of expand? Contract.
Compress.
Returns to normal. Does that make sense? It becomes smaller. And so if we fill our lungs with, we got this 760 moving in when we're down to 759. I know it's not showing it here. But with more air in, and now we create a smaller space, now we're going to increase the pressure of the air, the intrapulmonary pressure. Now we've got higher pressure inside the lungs than we do outside, and the air is going to rush out, or it's going to be pushed out. Now we're also going to have, surrounding some of the alveoli, we're going to have some sort of elastic properties. And I'm not going to say it's necessarily a ton of elastic fibers because we can't have a very thick membrane around alveoli. But these elastic fibers are also going to help to pull the alveoli back to shape. Because remember, these are little bubbles, and when you inhale, they blow up. And when you exhale, we need something to help them go back down. And so some of those elastic fibers are going to help us do that, and that's going to contribute to this total intrapulmonary pressure that we have that causes the air to pass outward until we have equal pressure outside and inside. It's like balloons. Honest to goodness, and I wish I had that little, bless you, that little model thing that would show you that. So this is just a little movie to kind of show you what this looks like. Not necessarily in real time. Come on. You see what's happening to the diaphragm down there at the bottom? And there you can see the ribs. Now, is this active or is this passive ventilation? Active or passive? You can't really tell. We don't have enough information here. But looking at the rate, I'm going to say this is passive. This is quiet ventilation.
Faster is active.
Faster and deeper is active. Plus, they've removed the external intercostals so you can actually see how the lungs, you notice the lungs inflating and deflating? Look at the size of the lungs. The lungs are mostly like sponges. You know, all the little holes in a sponge, those are like the alveoli. If you cut through the lung tissue, you would see the lung is mostly space, empty space. And those are the alveoli. Because how many do we have in each lung? Like 400 million? A lot. Yep, they do. Because your ribs are hinged on your vertebral column, and they're attached to your sternum. So yeah, they can move up and down like that. And in fact, when we get to the active breathing, the active inhalation, we're going to have other muscles around our neck and attached to our collarbone and stuff that are going to help raise the lungs even faster. And then our internal intercostals are going to contract in active exhalation. And when our internals contract, it pulls the ribs down faster. That way you can have more respiratory cycles per minute. Okay, so that was quiet breathing. Now, active. When you've run up some flights of stairs, when you're in the fourth quarter of a game, when you're doing a Spartan and you got a mile left to go, you know, you're breathing hard. And so the passive ventilation is not going to be enough to meet your oxygen demands of your body. So this basically is going to involve the same muscles that we have with passive, so diaphragm and external intercostals are going to be working here for inhalation, but we're also going to engage the scalenus. You remember some of these names from A&P1 and the muscles? The scalenus, it's going to be up here, okay, in your neck. Sternocleidomastoid, yep. Even your pecs are going to have a role to play, and your serratus anterior. These different muscles are going to be pulling in such a way that they're going to cause your rib cage to expand faster. Because again, it's not that you're going to breathe more deeply, which you can to a degree, but really these are so that you can have more respiratory cycles per minute to get the air in and out, because you're producing a lot more CO2 and you need to get more oxygen in exchange for that as well. Latissimus dorsi is another one. Now, for the exhalation part, we're still going to be relaxing everybody that we use to engage the inhalation, but this is where the internal intercostals are going to get activated, as well as this portion of your abdominal wall. Primarily it's your internal intercostals. And again, these are trying to help get the diaphragm and your rib cage back to the starting position faster so you can have more of our respiratory cycles. So only active exhalation is a time where you're contracting muscles during exhalation. For quiet exhalation, you just relax everything and gravity kind of takes over. All right, so here's another gas law that we need to examine. You remember Boyle's law said volume and pressure was an inverse relationship. Well, here with Henry's law, we're basically going to be looking at the fact that at a certain temperature, how much gas we can dissolve into a solution is going to be determined by the pressure of the gas and between the solubility coefficient of that gas in a particular liquid. Now, when we're talking about a liquid, we're principally talking about the plasma of our blood in this particular case. CO2 is going to be much more soluble in blood than is oxygen. And those are the two main gases that we have to play with.
What is partial pressure again?
Partial pressure, okay. So 760 millimeters of mercury, that is our atmospheric pressure in the air that we're breathing right now. How many different elements do we have in the air we're breathing?
Nitrogen, oxygen, and
We principally have nitrogen, oxygen, those are two biggies. We got some CO2, not a lot, and then we have some water vapor, which we don't really add that up a lot. But nitrogen, that's going to be a huge component of what's creating pressure. So 760, that is our total air pressure. If we take each one of those elements, the nitrogen, the oxygen, and the CO2, and what part of that 760 they're contributing, that's why we call that a partial pressure. Okay? Carbon dioxide, again, 24 times more soluble than oxygen, again, in plasma. Or you can think of this as water, because plasma is mostly water. And each one of these gases is going to require a certain partial pressure. That solubility coefficient is not enough for the gases to move quickly enough. You're going to have a certain amount of pressure on those gases to be pushed in. Oxygen, because it's less soluble, is going to require a higher pressure of the oxygen partial pressure than CO2 to diffuse into the blood. But CO2 is going to do it pretty easily. And that's fine, because the place where we're going to have the highest concentration of CO2, that is our internal respiration between our capillaries and tissues. And we want that CO2 to get into the blood and get out. So that's a good thing. So external respiration. Here we've got that picture again. We've got our alveolus, we've got our blood. Now we're adding numbers to get a better idea of how this movement happens. So if we look at the partial pressure of oxygen in the alveoli, of that 759 or 760 millimeters of mercury, we're going to say about 104 and 105 is attributed from oxygen. Now, we just came back in our venous blood. Our blood pressure was 0 by the time we got back to the heart. And then we got pushed that blood to the lungs. And so when we get to the lungs, our blood only has about 40 millimeters of mercury of oxygen partial pressure left. So, oxygen in the alveolus, 104. Oxygen in the blood of the capillaries in the lungs here, and that's our respiratory membrane. That's our type 1 alveolar cell. There's our endothelial capillary cell. So the gas is going to move. You can see why we move into the blood, right? Look at that gradient of pressure, 104 in the alveolus, 40 in the blood. Of course, the oxygen is going to move into the blood. How much energy is needed to move the oxygen into the blood? None. What's that process?
Diffusion.
Diffusion. Diffusion. It's absolutely passive. But here's the problem. We move oxygen from the lung into the blood, but which way do we need to move CO2? We got to move it in the opposite direction. Are we going to have to use energy to move it in the opposite direction? No, because look at the partial pressure of CO2. In the air that we're breathing, we only have 40 millimeters of mercury of CO2 partial pressure. We loaded up our blood with CO2 in the tissues, right? Now that's 45. So where's our high to low for CO2? In the opposite direction to go out. What process? Diffusion. That just kind of blows my mind that it's just set up in this way that the gases move in the appropriate direction without using energy. And it just so happens that direction is opposite.